So, okay. So what we'll do is we're going to start the course now. Is everyone ready to start? We'll start and we'll go straight onto the questions now. All yours, Doctor.
Okay, great. Thank you very much. Give me 1 second. Let's start right away. You guys see my face a lot these days. That is fine. I'm going to be with you all for a while. Anyways, yes, so we'll do the other stuffs later. We'll talk about what we're trying to do or what we are trying to achieve. I mean, the focus is that you make sure, the focus is that you pass the Krok and pass well. There are a lot of rumors out there. I've always told most of my students that you get a lot of rumors out there telling you that there's a high failure rate. And I mean, it's all about preparations. If you prepare well, if you know exactly what you're doing, there is no way, there is no two ways about it. You can't fail. It's not possible. So let's start today's session. At the end, we would see what I'm even talking about. So the very first question, I would need readers. Who can volunteer reading some of the questions? Who can read?
Volunteer.
Oh, nice. I've got a lot of volunteers. Can you repeat again?
I can read.
Okay, so the first person read the next 5 questions and then we move in that manner. Let's go. The male who spoke.
Oh, me.
Yes.
No, ladies first.
Oh,
Fair enough. They've overruled. Ladies first. The lady who spoke.
Okay, I'll read first and then.
Sure, that's okay. Go ahead, Sue.
Okay. A 16-year-old adolescent is diagnosed with hereditary UDP, uridine diphosphate, glucuronol transferase deficiency. Laboratory tests revealed hyperbilirubinemia caused mostly by increased blood content of the following substances.
Great. So you can see the options below, and you can see that 74.4% of the people chose unconjugated bilirubin. Over here inside the question, our most important, they give a lot of stories, but the most important key for us here is the UDP glucuronil transferase. You're supposed to know the reaction. If you know the reaction, or if you know what UDP glucuronil transferase does, you immediately would know the answer. So in knowing the reactions, we need to look at this important diagram. So you can see here, it's a very famous diagram. It's how the red blood cells are being broken. So red blood cells, red blood cells are made up of heme and it has hemoglobin on it. And the hemoglobin is made up of heme and globulin. The heme breaks down or can be broken down into unconjugated bilirubin. So the very safest way of remembering this almost every time is that unconjugated bilirubin is what is formed when red blood cells are broken. So it is located inside the blood. So that is our first key. So in case we have any destruction of red blood cells, like in hemolysis, or whatever the case is, unconjugated bilirubin is our guide. That is what would be increased inside the blood. Now, this unconjugated bilirubin goes to the liver, and with the action of the enzyme glucuronil transferase, very important, it turns it into conjugated bilirubin. So over here, they are telling you that the glucuronil transferase is absent. So let's cross it out, and then we can put a picture to it. So they are telling you that this enzyme is absent. There is deficiency of this enzyme. Clearly, this would be increased. And that is why the right answer is unconjugated bilirubin. When it comes to the concept of bilirubin metabolism, is something that you are asked almost every time. So you're supposed to know this diagram in and out. These are the questions that can come under it. In case there is increased hemolysis inside the blood, what do we see? We see an increased amount of unconjugated bilirubin. In case we see deficiency, or in case there is deficiency of glucuronil transferase, what do we see? We see an increased amount of unconjugated bilirubin. Now, the next level is the formation of conjugated bilirubin from unconjugated. So after glucuronil transferase adds glucuronic acid to it, it turns it to unconjugated, it turns it to conjugated bilirubin. And the conjugated bilirubin, the most important thing about it is what is transformed to bile. So that is what gets stored inside the gallbladder and later on released inside the duodenum. And when it's released inside the duodenum, it's broken down into two important metabolites, which is urobilinogen and stercobilirubin. The way I want you to remember this is the urobilinogen. Uro means urinary system. So the urobilinogen goes to the urinary system, whereas the stercobilirubin goes to the stool. It is very necessary that you know bilirubin is responsible for giving the stool its color. And secondly, it's also responsible for breaking down fat, or not breaking down fat, but what we call emulsification of fat. They would always ask you that question, that what is the function of conjugated bilirubin? The function is that it is used to form bile, and bile, the importance of bile is we can use it to form what we call, we can use it to break fats into little droplets. This means that if by any chance, where is my cursor? Why is it hiding, this mouse? Okay, if by any chance, for some reason, we have what we call a kidney, we have what we call a gallbladder stone. If there is a stone here, it means that this conjugated bilirubin that has been formed from the liver and is inside the gallbladder cannot travel to the duodenum. So for that reason, conjugated bilirubin would be reabsorbed back into the blood. So if we see cholelithiasis, or in case we have a blockage of the gallbladder, what would be increased inside the blood? Can anyone tell me?
Conjugated bilirubin.
Conjugated bilirubin from this diagram. And they like asking this question again and again and again. So unconjugated bilirubin, that is what we see when we break down red blood cells. Conjugated, and it is increased in case there is hemolysis in diseases like malaria. It's also increased in case there is glucuronidase deficiency. And then conjugated bilirubin is mainly increased when there is when there is what we call gallbladder stone formation. If that happens, it means that we cannot form stercobilinogen, because imagine if we block here, conjugated bilirubin cannot come to the duodenum, meaning this would not be formed, this would not be formed. So you would see the stool of the person to be what we call acolic stool. So they always bring that as well. Acolic stool, as soon as you see it, if they tell you that we cannot get, the stool cannot get its usual color, it is because we don't have stercobilirubin inside the stool. So they'll tell you what test should be provided to identify that conjugated bilirubin is not located, or what test should be done to identify that gallbladder blockage is present. And they bring nothing about conjugated bilirubin. If they bring stercobilinogen, they will tell you that stercobilinogen test is negative because of this blockage. Okay, so guys, do you get the concept over here? All the means or all the ways they can ask you the question. The first is about breaking of the red blood cells, where we see an increased amount of unconjugated bilirubin. The next is the deficiency of glucuronidase, where we see again unconjugated bilirubin increase. But now the next phase is when we see cholelithiasis, or blockage of the gallbladder. We see an increased amount of conjugated bilirubin. And when that happens, there is negative test or negative stool test in stercobilinogen. So the stool would not have color. So we call it acolic stool. So this diagram is something that you can have almost 5 or 10, 8 questions from it, straightforward. We'll keep that in mind. Okay. So let's go next. Who would read the next question, please? Anyone read?
A 26-year-old woman.
Laxon was the next one.
Oh, sure. A 26-year-old woman with bronchitis has been administered a broad-spectrum antibiotic as a casual treatment drug. Specify this drug.
Okay.
Yeah, sorry.
So over here, they are telling you about bronchitis. We have a lot of drugs we can use to treat bronchitis, but the most important thing for us here is to know this term. Which of the following is a broad spectrum antibiotic? That is the question they're asking you. And we all know that the broad spectrum antibiotic here is doxycycline. Now tell me, dexamethasone, what group of drug is it?
Steroid.
Steroid. You say it's a long-acting steroid. What about ambroxol?
Antitussive.
Antitussive drug.
It is not an antitussive drug. It's what we.
I mean, it's a mucolytic. Mucolytic.
It's a mucolytic. It's a mucolytic. So keep that in mind. Mucolytic. It's there to break down mucus. Why? I mean, does anyone know why you can constantly lose your mouse when you're dealing with Zoom? Anyways, this is the keys here. Ambroxol is a mucolytic. Dexamethasone is a long-term corticosteroid. BCG is a vaccine mainly used for tuberculosis. Interferon is an antiviral drug. So keep that in mind. The next question is, they're saying that the person, okay, go ahead. Who would read it for us?
Yep, a 40-year-old woman was diagnosed with glomerulonephritis based on her clinical symptoms and the results of urine analysis. Amnesis states chronic tonsillitis of what microorganisms are the most likely cause of the kidney damage in this case.
Okay, give me 1 sec. I'm trying to find. Okay, so here, the keywords that we have here is one, glomerulonephritis. So we are seeing glomerulonephritis, and the other thing that they are stating is that in the past, she had chronic tonsillitis. She had chronic tonsillitis. Anamnesis means the story of the person, in the history. So she had chronic tonsillitis in the past, and there is glomerulonephritis. So who knows? Who can tell us what is the diagnosis? Whenever you see this combination, anytime, what is it?
Streptococcus.
No, I need a diagnosis. The full diagnosis.
Is the
Rheumatic.
So it's mainly called post-streptococcal glomerulonephritis. Post-streptococcal glomerulonephritis. Streptococcus is a very interesting bacteria. It's sort of, I should say, it's a bit sly in a way, because some of its antigen looks exactly like some components of the blood or some components of the body. So when it gets inside the body tries to attack it. When it attacks it, it leads to some of the components of its antigen is also located inside the heart. So if you see the person had tonsillitis in the past and they are currently having a heart disease, straightforward, Krok 1, Krok 2, anytime, if there is past history of tonsillitis or a sore throat, and currently they are having a heart disease, it's mainly because there is destruction of the streptococci antigen, and the streptococci antigen chemical structure exactly looks like some chemical structures in the heart. We call it the molecular mimicry mechanism. Mimicry, it behaves like the body. So whenever you see these two combinations, the most important thing you think about is, can anyone tell us?
Normally, it's the rheumatoid arthritis that is caused by the streptococcus, which is strep throat. When you get strep throat, your body starts producing all the antibodies against the strep.
Right.
Yeah, that causes. Yeah.
Right, beautiful, well done. So what we see is rheumatism or rheumatic fever.
Yeah, rheumatism, yeah.
Right, so whenever you guys see streptococcus infection or whenever you see sore throat and you see an issue with the heart, immediately, you don't think twice. You don't bother yourself you don't bother yourself much. In Krok 2, we say a sore throat plus murmur inside the heart, it is rheumatic fever. Whereas a sore throat with glomerulonephritis, a sore throat with a kidney problem is post-streptococcal glomerulonephritis. Who can tell me the post-streptococcal glomerulonephritis, what kind of hypersensitivity is it? Which type?
Is it type 3?
Okay, what is the name for type 3?
Is it like that it forms complexes?
Exactly, they form an immunocomplex. That is the antigen and the antibody that has been produced to fight it. I mean, they've called the sort of, you have soldiers inside, you send the soldiers to go and fight someone. And when they get there, the person is so strong that they hold each other and they keep fighting till they get deposited in the gutters. And the gutters are the kidney. When they get deposited there, there is what we call an immune reaction to begin the process of kidney destruction. So when you see that, you're thinking, so the disease here is, or the right answer here is streptococcus. Streptococcus. So the full diagnosis for this patient is what we call the post-streptococcal glomerulonephritis. In this set, there are two main things you can be asked: rheumatic fever and post-streptococcal glomerulonephritis. Keep that in mind. You can see that here. That is the key. Okay, let's go to the next question. You can continue reading, please. Yeah, look.
41-year-old man has a history of recurrent attacks of heartbeats, paroxysms, profuse sweating, headaches. Examination revealed hypertension, hyperglycemia, increased basal metabolic rate, and tachycardia. These clinical presentations are typical of the following adrenal pathology. Nice one.
The key words here we need to be paid attention at. A history of recurrent heart attacks. I mean, it's recurrent, just happening again and again. The most important key word here is paroxysms. Paroxysm means recurrent, or it happens once a while and it happens again after. Right? It's repetitive in a way. So it happens, goes down, happens again, goes down again. And then there is profuse sweating and there is headache. What do you think? Increased heartbeat with profuse sweating. Which hormone can do that?
Would it be epinephrine or no epinephrine?
Epinephrine is the guy. So that is the sympathetic system. It's like you are trying to run. You see, when you are running, there is an increased heart rate and there is also sweating to an extent. And that's what epinephrine does. We can also see the headache because of the function of epinephrine. In this case, examination revealed hypertension, epinephrine. Hyperglycemia, again, is epinephrine. Because you should know that epinephrine and norepinephrine are what we call the contra-insulin hormone. That is, they are able to increase glucose inside the blood. That is why when you are very stressed, do you feel hungry when you're stressed?
No.
Yes, you will clearly not feel hungry when you are stressed. When you're stressed, it's like you're very satisfied because epinephrine and corticosteroids are on the high. What they do is that they increase the sugar level inside the blood, and that will lead to you not feeling as though, or you not feeling hunger at all. There is also increase in basal metabolic rate and there is tachycardia. So now we know that it is epinephrine and norepinephrine. We know that is the diagnosis. But the next thing they want to ask you is, where is epinephrine and norepinephrine released? This means that they are increased. The amount is increased. So the question is, where are they released from? Exactly. It is the medulla of the adrenal gland. So inside the medulla of the adrenal gland, we have a release of epinephrine and norepinephrine. That's where they are formed and released. When we release, because here we are having an increase of the activity, it means that they are released too much. And it happens in only one thing we are tested on. Can anyone help us? What is the disease in this case?
Is it pheochromocytoma?
Pheochromocytoma is the right answer. Pheochromocytoma. It is a tumor inside the adrenal medulla. A tumor inside the adrenal medulla leading to an increased release of epinephrine and epinephrine. And that is why the person is sitting down, but it feels like he's on a run. He feels like he's having an Olympics. And these people, interestingly, can get very angry immediately. So some of us, I'm sure we have pheochromocytoma. So make sure you check your kidneys, okay? So here, the right answer would be, can anyone help us? What would be the right answer here?
Hyperfunction of the medulla, no?
Right, hyperfunction of the medulla. Where is it? Hyperfunction of the adrenal medulla. This is it. So 41.9% of the people got it right. Let's see the people who chose green. The hyperfunction of the adrenal cortex. I'm sure they chose that because of the release of corticosteroids. But increased corticosteroids is important that we know the disease over there is what we call, can anyone help us?
Cushing syndrome, right?
Cushing syndrome. Cushing syndrome. And also, they might also think that it might be the increased release of aldosterone. Increased release of aldosterone. The disease is called Crohn's disease. And let's first talk about Cushing syndrome. In Krok, Cushing syndrome, the two things that they would always bring is the moon-like face and the strias. They would always bring these two things. So whenever you see the person or you hear something like the person is having a moon-like face, that is when you are thinking about the adrenal cortex. But if there is nothing about moon-like face and these weird symptoms of the person can get in feeling as though he's on a run or something, that is when we get worried about pheochromocytoma. So in pheochromocytoma, these are all the things they can test you on under pheochromocytoma. This is the keys that you need to know. But the test is also very important, which is the VMA test, the vanillyl mandelic acid test. Why do we do this test? To identify pheochromocytoma. But why are we choosing? Why? Okay, I guess it's already written here. Vanillyl mandelic acid, VMA, is a byproduct of catecholamines. Just like you see, acetylcholinesterase breaks what? What is the function of acetylcholinesterase?
Break down acetylcholine.
Right, it breaks down acetylcholine. Monoamine oxidase breaks down catecholamines and other stuffs, but we'll talk about the other stuffs as we move on. Monoamine oxidase breaks down catecholamines, it breaks down serotonin, it breaks down dopamine, it breaks down all these guys. When it breaks them down, especially if it breaks, what do we call, if it breaks epinephrine or the catecholamines down, it leads to the formation of vanillyl mandelic acid. And that is why we do this test. And we just say safely that when we have an increase in catecholamines, it means that we would have an increase in breaking them down. And that is why we see an increased level of vanillyl mandelic acid inside the urine. When that test is positive, whenever you're reading any MCQ, VMA positive, don't bother yourself. It is always pheochromocytoma. That is what we are mainly worried about. And the enzyme that helps in the breaking down is the monoamine oxidase. You are also tested on this enzyme. It breaks down catecholamines, serotonin, and dopamine. Okay, next question, please.
A 6-year-old child with suspected and active tuberculosis process has undergone diagnostic Mantoux test. What immunobiological preparation was injected?
Right. So here they are saying a lot of stories. The key word here for us is you're talking about Mantoux test, and you should know what a Mantoux test is. A Mantoux test. Can anyone help us? Anyone knows what is a Mantoux test?
Is it a type 4 cellular reaction that sees if you've been exposed to tuberculosis before or not?
Right, beautiful. So a Mantoux test is a test that is done to identify whether you have an immunity to tuberculosis or not. The word immunity just means, have you been exposed to it before or not? If you've been exposed to it before, then the body has already prepared a memory of how they should attack it in the future. So in that case, we do, so the Mantoux test, when we do it and it's a positive test, it means that you've been exposed to tuberculosis before or you've been vaccinated with tuberculosis. If it is negative, it means that you have not been vaccinated or you've never been exposed. It means that if you get tuberculosis right now, or if the bacteria gets to you right now, it will cause damage. So that is why the test, or the way we do it, is that we inject the toxin of tuberculosis under the skin and we watch the reaction. If we see that there is no reaction, that is where we get worried. We are like, okay, it means that they don't know this new guy coming in. So the toxin of tuberculosis is what we call tuberculin. Sometimes people confuse this a lot. They choose BCG vaccine instead of tuberculin. Always remember, BCG vaccine is a vaccine. So the vaccine is given in case we see that Mantoux test is negative. The Mantoux test is the introduction of the tuberculin itself, which is the toxin. After we introduce it and we see that it's negative, it means that the body doesn't know about tuberculosis. If it doesn't know, then let's introduce the vaccine, the BCG vaccine, into the person so that the person, the immunity of the person will learn about tuberculosis so that upon subsequent exposure, there is already a predisposed immunity ready to fight it. Okay, you see the dynamics. So BC in Mantoux text, the content of the test is tuberculin, not BCG vaccine. I think I've even made, when I was in third year, it's fine. When I was in third year, I didn't even know the difference. Okay, so these are the keys you're supposed to know about it. You can see the test is a type 4 type of hypersensitivity. We would need to change this. This is not an immunocomplex. It's rather a cellular type of hypersensitivity. So pay attention. This is not an immune complex. It's a cellular type of hypersensitivity. So when the BCG test is negative, it means that we don't have immunity against tuberculosis. So what we do is we give the person a BCG vaccine. You would always be asked this question. We were doing an investigation in some group of children. We realized that Mantoux test is negative. What does it mean? Negative, or the person does not have immunity against tuberculosis. And then the next time again, no, Mantoux test is negative. What should we do? We give the person a BCG vaccine. So this is the Mantoux test. You can see if the reaction is positive, this is what we see. If the reaction is negative, we don't see anything at all. Okay, next question.
A 63-year-old man who has been suffering from chronic fibrous cavernous pulmonary tuberculosis for 24 years has been delivered to a nephrology department with uremia. Intravital diagnostic tests for amyloid in the kidneys are positive. What amyloidosis is it in this case?
Our most important key here, in Krok as usual, there are a lot of stories. The very first thing is they are talking about amyloidosis of the kidney. They are saying that the amyloid test inside the kidney is positive. Our next key is that, okay, so what caused the amyloidosis? Did the amyloidosis come by itself? I mean, was it genetic or it was due to something? And we can see that the person has a previous infection or he has a previous chronic inflammatory disease. This is what we can see here. A chronic inflammatory disease, which is tuberculosis. In every chronic inflammatory disease plus any kidney infection, if you are being tested on the deposition, if you are not being tested about allergy, the other thing they can test you on is always amyloidosis. What is amyloidosis, or what is amyloid bodies?
Misfolded proteins.
Thank you very much. Amyloid is just a misfolded protein. So when the protein is misfolded, it can get deposited. So now the interesting question is, we have primary systemic, or we have primary or hereditary amyloidosis, which we see, that is what we see in genetic predisposition. So the person is genetically predisposed to have misfolded proteins. We have what we call a senile type that is seen in elderly patients. I mean, as they grow older, they have misfolded proteins. It's seen in Alzheimer's disease and all the others. And we have a secondary systemic amyloidosis, which is caused by what we call a chronic inflammatory disease. The reason why it's called secondary is because it has a cause. It is not genetic. It didn't happen by itself. It has a cause before. So the question is, why do we see secondary systemic amyloidosis? Why do we see after chronic inflammation? Why do we have a high tendency of getting amyloidosis? Can anyone help us?
Is it because the body like still produces lots of antibodies and then eventually they kind of...
Beautiful, because there is a constant production of antibodies that can get what? Misfolded. Even if they don't get misfolded, when they get accumulated so much, they can be deposited inside the kidney, the spleen, and what have you. And that can lead to amyloidosis. So here, these are our most important keys. Let's go and see what, so amyloidosis is a misfolded protein. The test that we do is a Congo red stain, a Congo red stain. The primary, we spoke about it, and the chronic, we also spoke about it. Thank you. Let's go to the next. And by the way, myeloma can also lead to amyloidosis. Why? Multiple myeloma.
There's a high turnover of immune cells, which results in the light chains, was it lambda and kappa light chains being produced?
Exactly the point. In simple terms, what he's trying to tell all of us is there is increased formation of, myeloma is just a cancer of the bone marrow. And in most cases, there is increased formation of B lymphocyte. Increased B lymphocyte, increased tendency to form immunoglobulins, and more immunoglobulins, more chances of having a misfolded immunoglobulin, which can be deposited in different areas, which is which becomes our amyloid bodies. Right. Let's go to the next one.
A 7-year-old child, has acute onset of disease, temperature rise.
Wait, Christopher, did you say a 70-year-old child?
7-year-old child.
Oh, okay. I thought the child is 70.
No, a 7-year-old child has acute onset of disease, temperature rise up to 38 degrees, rhinitis, cough, lacrimation, and large spot rash on the skin. Pharyngeal mucosa is edematous, hyperemic, with whitish spots in the buccal area. What kind of inflammation caused the changes in the buccal mucosa?
Okay, great. In simple terms, what you can see here is the famous friend Qatar. I'm sure all of you know Qatar by now. Qatar inflammation is the inflammation of the respiratory system, which leads to an increased formation of the how do we even call it? Increased formation of the mucus, the mucus. So here our key goes as follows: rhinitis, cough, lacrimation. This is a classic presentation of catarrh. The other things can confuse you a bit, but they are talking about rhinitis. When you have rhinitis, we in Africa, for instance, we just know rhinitis as catarrh. We don't even call it rhinitis. So when you say catarrh, it just means rhinitis. I never knew the name rhinitis till I started med school. So keep it in mind, rhinitis is this three, or is this triad. You having so you having rhinitis with all of that, then that is a catarrh inflammation. So guys, can you tell me, a fibrinous inflammation, what do we see?
Would they form like grayish films?
Exactly the point. There is release of fibrin. Now you need to know the color of fibrin. You see, when you're trying to differentiate all the others, the most important thing about them is that it is only coloring. This one, we are going back to kindergarten. It's mainly about coloring. So for fibrinous inflammation, we see gray spots, or we see gray films because fibrin is gray in color. In fibrinous inflammation, we have two types. We have what we call a diphtheric and a corpus. Can anyone tell us the difference?
Is diphtheric the one that's like... No, go for it,
It's just how intimately they join to the membrane. And if you remove it, the diphtheric is very...
The way they would always ask about diphtheric is that, can we, the way they would differentiate fibrinous type of inflammation, the two of them is, can the film be easily removed? Okay. Yeah, can it be easily removed or not? So for diphtheric, they'll tell you upon removal, it is very difficult. And the second thing is upon removal, we can see bleeding. It's all because in diphtheric type of fibrinous inflammation, the fibrin attaches itself very strongly to the mucosa. Whereas in Krok Krok type of inflammation, we can easily remove the fibrin films. The grayish film, we can easily remove it without any problem. Okay, the next is the hemorrhagic inflammation. What do you think would be the color?
Red.
Red, hemorrhage. So you see red blood cells in it. Hemorrhagic inflammation. Serous inflammation, what is the color? Clear fluid. Clear colorless fluid is mainly because we don't have anybody going in. We just have some fluid and some proteins, little ones that are there. And that is normally what you get when you burn yourself with the iron. I'm sure all of us have had that experience before. Just remember how the burn looked like. The next one is suppurative inflammation. A suppurative inflammation is when, or sometimes we call it, yes. So suppurative inflammation, can anyone tell us the color?
Is it like yellow greeny?
Yeah, exactly. It is yellow, specific, yellow green. It's like a pus. The main reason is because in this case, the neutrophils are there. The white blood cells are there. And if white blood cells are there, as their word implies, they look white, but mainly we see them as yellow. Okay, so here it is. You can see the most important keys that are given here. All these phases are the exudative phase of inflammation. We have 3 phases of inflammation. Can anyone help us? First phase.
Alteration.
Alteration, beautiful. Alteration is divided into secondary and primary. If you don't know, write it down and then go revise it. Second phase.
Exudative.
Exudation. And final phase?
Proliferation.
Proliferation. Amazing. You guys are doing very well. Let's see why everyone, oh, it's anatomy. That is why the circle is very, guys, this question, someone read it for us, please.
A child has a wound located posterior to the mastoid process. Bright red blood flows from the wound. Damaged are the branches of the following artery.
Okay. So where is the mastoid process located, first of all?
Like behind the ear?
Behind the ear. So the first thing here is they are telling us posterior to the mastoid process. So behind the ear, So sort of behind the mastoid process, and the mastoid process is located behind the ear. And what region of the body is there?
The occipital.
Occipital.
The occipital. So even with this one, a guesswork could have done it. You see, in anatomy, don't always give up. Sometimes you should try and guess well. Like, it's about active recall. But sometimes try and guess. Temporally superior, where would it be located? Would it be behind the ear or in front of the ear?
In front.
In front of the ear, because the temporal bone is located in front of the ear. Maxillaris, where would it be located?
The jaw.
At the upper jaw.
Upper jaw, right. That is it. And then carotid externa, where would it be located?
Inferior to the
neck.
Yes, it's located inside the neck somewhere. And then we have carotid interna, so located inside the neck, and it passes and goes inside the brain. So over here, if you took your time to guess well, you would understand that the best one to choose is occipitalis. Next question.
A comatose patient was taken to the hospital. He has a history of diabetes mellitus, objectively cosmal breathing, low blood pressure, acetone order of breath. After the emergency treatment, the patient's condition improved. What drug has been administered?
Right, beautiful question. So in this case, there is the patient is comatose. There is cosmal breathing. What diagnosis is this?
It's diabetes.
Person has diabetes mellitus, they are comatose. They have a diabetic coma. Which kind of diabetic coma is it?
Ketoacidosis.
It is ketoacidotic coma because of Kussmaul breathing. Anytime you see Kussmaul breathing, it's ketoacidotic coma. Try and look for Kussmaul breathing and understand. And in every coma of diabetes, how do we treat it?
Insulin.
Insulin. Any coma of diabetes, as soon as you see any coma,
IV.
as soon as you see any coma, you go for insulin. You don't go for glibenclamide. Because glibenclamide is to treat or to manage diabetes at the long term. Well, if there is coma, if you give the person glibenclamide, they will wake up in 20 days. So by 20 days, they are gone. Maybe you give them the remaining glibenclamide in their grave, okay? So that is it. That was just by the side. So here are the keys about the drugs of diabetes. You can review that yourself. If you give too much insulin, how can you, and the person faints, how can you counteract the reaction?
Give
Glucose.
You can give the contra-insulin group of drugs, which is you can give glucose, or you can give epinephrine, norepinephrine, and corticosteroids, and even, which other one? Can anyone tell me? There is a last one, a friend of insulin.
Metformin.
Glucagon. Okay, this is an interesting question. There is no much, the time is not too much. So let me just try and then underline here. They are talking about diphtheria, right? The dosage of bacterial diphtheria. And they're talking about what can be used to measure the mortality rate of diphtheria. The measuring of the mortality rate of diphtheria, the right answer in this case is the answer that contains the word M, the mortality rate. So it's diphtheria mortality rate. So let's try and find it. So over here, these are the tests about diphtheria, but over the past years, you are never tested on these different, how do we say, virulence tests. You are only always tested on DLM. You've never been, the DLM question even came once or twice. So always the doses letalis minima, it means, or is the minimum mortality dose. So that is why the right answer is DLM, because here we are talking about the mortality dose. There are other ones, you can look at it. Okay, let's go. Next question. Who would read it for us?
A passenger of a Finland taxi has a sudden and expressed attack of tachycardia. The doctor traveling by the same taxi has managed to slow down his heart rate by pressing upon the eyeballs and thus causing the following reflex.
Pressing upon the eyeball and the person's heart rate decrease. Straightforward, what are we thinking about? It's called the Dagini-Ashnas reflex. The Dagini-Ashnas reflex. The other name for it is the oculocardiac reflex, meaning you press on the eye, it has an effect on the heart. It is because of the vagal reflexes. We spoke about it some time ago, but vagal reflexes are a group of reflexes that when you stimulate, it leads to a decreased heart rate. Sort of you're stimulating the vagus nerve. The other reflexes, we've spoken about them, they are here. Frank-Sterling's law or Frank-Sterling mechanism, very important reflex that you are also tested on in most of the cases. We have an increase in the venous return, increases the force of contraction. The force of contraction. I think that this was a mistake, but an increase in the venous return leads to an increased force of contraction. The way I explain this to my students always is that when you have a rubber band, you extend it very much. The more you extend it, the harder they come back to hit. And that is your Frank-Sterling law. That is why when you dilate the atrium too much and you release it, it comes back very strong to hit it, which increases the heart, the force of contraction. The other ones are not very necessary. The first two are very important, but I've also written about the other ones, which is something you can look at. Next question. They are talking about loss of sensitivity in the little finger. This is it. Loss of sensitivity in the little finger. Which one does that? The only one that can do that is the ulnar nerve.
Ulnar.
Sensitivity in the little finger. Always remember the ulnar, the little finger is located in the ulnar region. It's located in the ulnar region. So this is the nerve supply. So you can see the ulnar nerve supplies the little finger and half of the fourth finger. whereas the median nerve supplies the first three finger, 1, 2, 3, anteriorly. But posteriorly, the ulnar nerve supplies the little finger again posteriorly. But for the posterior side of 1, 2, 3, and half of this is mainly done by the radial nerve. When we used to be in medical school, we always drew this diagram on ourselves so that we can always remember. Oh, it's nice to say when we used to be in medical school. Anyways, let's continue to the next question. This is talking about, anyone read this for us?
A patient complains dizziness, chest, difficult swallowing, and impaired vision of close objects has addressed the doctor. Objectively, respiratory rate is increased, pupils are dilated, general agitation, talkativeness, though the speech is indistinct. BP is 110/70, heart rate is 110. Given symptoms can indicate overdose of the following drug.
Okay, the person has a dilated pupil, that is 1. The person is facing difficulties in swallowing, that is 2, which means we have an issue with the muscle. We have an issue with the eye, that is dilated eye. And then the person also has what we call the increased heart rate, but is marginally increased. Is the person sweating or not? Dizziness. Okay, the person is not sweating. But with these 3 things, we can safely say that it is due to a blockage of the parasympathetic system, or is a blockage of the cholinergic group of receptors. So that is why the right answer in this case would be atropine. Atropine is an M-cholino blocker. Because it's an M-cholino blocker, that is why we have an issue with swallowing, which is your most important key here. Because inside the digestive system, if we are seeing the digestive system, if it is not moving, it means that we have an issue with the parasympathetic system. Because parasympathetic system is what? Rest and digest. Okay, keep that in mind. Okay, so these are the keys about atropine, everything you need to know about this drug, what it does, and the way we can treat this important overdose is to give Prozarin. What is Prozarin? What group of drug is it?
Anticholinesterase.
You said anticholinesterase?
Inhibitor.
It is a cholinesterase inhibitor.
Like
Okay.
neostigmine of first.
Yes, it's neostigmine, that is the other name, neostigmine, and the other group. Okay, I don't know why this question, we had a lot of mistakes, but tell me, the person is having, you're saying that the person has urinary system blockage by a stone. And they continued by saying that it is located between the region of the abdominal and the pelvic segment.
Isn't that the ingul?
What?
Isn't it the blue one, the linea ingularis?
No, linea inguinalis is the inguinal line. The inguinal line is located at the groin. I mean, that is just the line above the at the groin area. The linea semilunaris, where do we find it?
In the testes?
Again?
I'm not sure, but is it in the testes?
No, that is the seminiferous tubule. The linea semilunaris is mainly located on the rectus abdominis. The word means semilunaris, half moon. So if you check on the rectus abdominis, on the sides, the lines are like half moon. I mean, people who have 6 packs, you can look at your packs right now, but some of us, we cannot look at it. So even for some of us, we just need to go to anatomy book. But those who have 6 packs, you can look at it now. You see your linea semilunaris. The next one is this one, the linea terminalis. This is it. This line. I don't know. You forgot this line, guys, where the urethra transform into the abdominal urethra transform into the pelvic urethra, this region. It is very narrow because of the transformation. And so mainly the stones can block there. So that is our linea terminalis. Keep that in mind. This is the key that you're supposed to know about it. Next question. Anyone ready to read?
A patient consulted a physician about chest pain, cough, fever. Röntgenography of the lungs revealed eosinophilic infiltrates that were found to contain lava. What kind of helminthiasis are these?
Beautiful. Always, almost every time. Eosinophilic infiltrate plus lava plus pneumonia. So pneumonia signs plus eosinophils plus lava. The only guy who is stubborn enough to do that is ascariasis. Ascariasis is very funny in such a way that the two things that it can do that are dangerous is that it can give you pneumonia. And when you begin to cough, the lava comes out of it inside your sputum. And you can see eosinophilic infiltrate because eosinophils normally go high when there is a helminth infection. The second thing they can also do is that they are so huge to the extent that they can block your intestine. Sometimes I call them the spaghetti of our intestine. So when they grow too much, they become like spaghetti, like real spaghetti, and they can block the intestine. So here are the keys that you're supposed to know about it. One sec, I'm finding my bearing. Right. So this is everything you're supposed to know about Ascaris lumbricoides. You're supposed to know about the egg. Every word here is very important so that in whatever way they twist the question, like you grab it, okay? You'll be like a red blood cell. Whatever means it would use to pass inside the arteriole, it would go in. And these are the other ones, the Tracherius, Trachea, and the Echinococcus. Realize that some people chose Echinococcus. For your information, Echinococcus in most cases, they would always bring dog because it's transmitted by a dog. So always, if you don't want to even learn about it, remember dog is Echinococcus. Tracherius, Trachea, they'll always bring pork. So keep that in mind in most cases. But the egg, you're supposed to know how the egg looks like. Okay, this is a very simple thing. The person has an infection. The kind of test we should do is, let's see, what is this? The person has dysentery for 3 days in the infection. I mean, what test do you think we should do?
The widow's test.
Right. So why did we all choose feces? For 3 days, the dysentery is not much enough to be in the feces. So the best one that we should do is the blood test. So we should check the blood for antibodies against the disease. Okay, next one.
Dr. Mustafa, can you explain that again? Why is it blood, not feces?
Okay, so in blood, inside the feces, in most cases, we are not able to see them enough. Like when we do the feces test, we are not able to get, because it's 3 days, it's too short. Yes. So normally the antibodies are more detected inside the blood rather than seeing the real structure inside the feces in the first 3 days.
Would you not check the feces for like the organism?
Yes, in the feces, we do the bacteriological test to check for the organism itself.
But in this question, also if it doesn't specify it's looking for the organism, we should assume that they're asking about the antibodies.
Okay. Yes, you should assume that they're asking you more about the antibodies because of the 3 days, because it's too short. For that reason, it is best to check inside the feces. Sorry, it's best to check inside the blood antibodies against it, or than to check inside the feces to look for the organism.
Oh, okay. Thanks.
Doctor, how many days would it take for it to be in the feces?
Normally after 7 days that we can really identify them. Okay, let's go next. This person has an issue with head muscle. So the motor center, where is the motor center located? Can anyone remind us?
Medulla.
The motor center, the center for controlling movements on the
Precentral gyrus.
Precentral gyrus in front. So always remember, when it comes to the motor system, we have the first order neuron, or the neurons are located in the anterior horn, or the muscle, the things that control movement. The impulses come through the anterior horn, and we translate them, or we send the impulses by the precentral. All of them are in front, anterior, precentral in front. Now, in the precentral gyrus, you're supposed to know that the head is located inferior part of the precentral gyrus, whereas the leg is located at the superior part of the precentral gyrus. So you see, you can test you on that here. So keep that in mind. One sec. So that is why the right answer is the inferior part of the precentral gyrus, because they're talking about motor and they're talking about the head. So that is this diagram you can see here. Those are the keys you're supposed to know about it, about all the gyruses. Okay, next question is about the asking a fluoroquinolone. They were specific that you should give a fluoroquinolone. Yes, there are other antibiotics, but you should give a fluoroquinolone. The only fluoroquinolone here is ciprofloxacin. Here, the person in pleurocentesis yielded 700 milliliters of yellow greenish fluid. The yellow greenish fluid, what do you think? What do you think yellow greenish fluid is made up of?
Neutrophils.
Neutrophils. So the right answer here would be a pleural empyema. Empyema is a type of suppurative inflammation that is mainly located inside what? Inside the pleural cavity. So whenever you have a suppurative inflammation inside the pleural cavity, a lot of pus inside the pleural cavity, we just call it an empyema, So this is the usual word. Sometimes they use 700 milliliters or 900 milliliters. That is what you can see here. Here, the person, interestingly, was injected with heparin. And currently, they are overbleeding. And they're asking you, what is the heparin antagonist? What is the heparin antagonist here?
Vicazole.
Protamine.
Vicazole is vitamin K. So it's mainly the sort of the antagonist that is used for when you use warfarin. So warfarin is Vicazole, whereas heparin is protamine sulfate. Those are the major antidote. These are the keys about it that you can know. Beautiful. Yes, who wanted to ask a question? Okay, right, let's continue. What happened with this question? The person is a sick person and they are currently lying, or they've been sitting in a forced position for a very long time. When you sit in a forced position for a very long time, or when you lie in a forced position for a very long time, and you are having some dark brown lesions, whenever you see dark brown lesions on anything related to necrosis, then it is a gangrene. Any dark brown lesions or dark lesions, if it is related to necrosis, then it has become a gangrene. It's sort of rotten, like in that way. And because the person is sitting on a specific area for a very long time, there's a decreased blood flow to that area. So it leads to what we call a bed sore type of gangrene, because they lie there for a very long time. So the right answer here is bed sore. It's bed sore.
Can I just ask, you said any dark brown thing is gangrene. So why not dry gangrene? Why bed sore?
Right. It is only the reason why it's not dry gangrene is because, first of all, the history is telling us. The history is saying that she's sitting in a forced position. She's lying on the bed in a forced position. That is one. The second thing is they are saying that it is swollen and it has a smelling fluid. Whenever there is fluid, whenever there is inflammation, it cannot be a dry gangrene. Yeah. It's only when, so this is a wet type of gangrene, and this wet gangrene is called, to be specific, a bed sore type of gangrene. So here you are, you can see the keys here. Okay, but why did we make this mistake? Okay, so here the person has an intestinal infection and you check the bacteria or you check the contents of the feces. They give you a lot of description and you can see cilia. Whenever you see this, cilia, it is the most important differentiation factor for balantidiasis. Straightforward, no two ways about it. For other ones, lambiliosis, for instance, you normally need to see a pear-shaped organism that has 4 pairs of flagellates on both sides with 2 eyes or with 2 nucleus. Sort of, I call it the monster amongst all of them because of the way it looks like. You can check the image. So these are the key about balantidiasis. Most other people choose lambiliasis. Lambiliasis is not possible because that is for Giardia. The description doesn't fit. The description only fits for balantidiasis. GI symptoms plus organisms with cilia. And sometimes the key they like bringing recently is a micro and macro nucleus. It is balantidiasis has 2 nucleus. One of them is big, the other is smaller. Okay. Okay, so yeah, this was an interesting one. Whenever there is thiamine deficiency, what does it lead to? What disease does it lead to? Tell me.
That is beriberi.
Beriberi is correct. So beriberi is correct. In thiamine deficiency, there is beriberi. And whenever we have deficiency in thiamine, the reaction is that it blocks the reaction of conversion of pyruvic acid to acetyl-CoA. And when that reaction is blocked, what gets increased is that we have an increased amount of pyruvic acid, not phenyl pyruvate. It is not phenyl. You shouldn't confuse between pyruvic acid and phenyl pyruvate. It's only phenyl pyruvate increases only in a disease called, can anyone help us? Anyone knows? In phenylketonuria. Phenylketonuria, as the name would imply, PKU. Phenylketonuria, it leads to an increase in, look at the name, it's called phenylketonuria because you are urinating a phenyl ketone. That is what you're seeing here. Pyruvate is a ketone. So phenylketonuria is phenyl pyruvate urea. You are urinating phenyl pyruvate. So always you think about that in case of PKU. Okay. That is the keys you're supposed to know. Everything about vitamin B1, you're supposed to know the other name, thiamine pyrophosphate. You're supposed to know about the enzymes that it affects, pyruvate dehydrogenase and alpha-ketoglutarate dehydrogenase. And the 2 most important disease, which is beriberi, we have the dry form of beriberi and the wet type of beriberi, which we call the Wernicke's disease. It's normally seen in people who drink a lot of alcohol. Okay, great. Over here is interesting because we had, they give you a description of a lymph node. But some people, I mean, the description is that in the cortex, you can see lymph nodule, and in the medullary cortex, they are made up of lymphoid cells. Some other people choose, most people choose the lymph node, but other people choose the spleen. The most important distinguishing factor between the lymph node and the spleen, they are both the same. The only histological difference is the spleen has what we call a central artery. So you would always see at the end of the question, there is a central artery. When you see that, boom, you've got your answer right. You're going for the spleen. Other than that, their description are almost every time the same.
So what is the correct answer, don't understand?
The correct answer is tonsil. Sorry, it's a lymph node. It's a lymph node. So lymph node, but it can also be the spleen if only we have a central artery. Okay, so let's take a 5 minutes break and then we return. Thank you very much.
Scrape. Soft meninges of phoenix and base of the brain are edematous and saturated with blood, cardinal's cap. Microscopically, we see serous hemorrhagic inflammation of meninges, and cerebral tissues make the diagnosis.
Right. What do you think should be our case here?
The dark
agriculture enterprise.
One is agricultural enterprise. What does it tell you?
Cattle.
Tells you about soil Something that has to do with the soil.
Right. What else? What other thing? Someone spoke about the
dark cherry red, yeah.
Dark cherry red section of
I
the
think black, yeah. Some questions.
Okay, what else?
Cardinal's cap.
Cardinal's cap. What is cardinal's cap? Okay, so look, this is everything you're supposed to know about anthrax. Anthrax is formed or is caused by a bacillus, and this bacteria is a spore-forming bacteria that normally finds itself in soils. Because it is a spore-forming, so it can stay in soil for hundreds of years. So the areas, whenever you're reading a question and it's talking about agricultural enterprise, it's talking about a cattle graveyard, it's talking about a human graveyard itself, whatever it is, so far as it has to do with the soil, for some reason, or the carcass or feces of a cattle, you're thinking about anthrax. The next thing you are worried about is you're also worried about yes, the dark red appearance of some organs. Then whenever you see dark, that is important. And the final one is the cardinal cap. The reason why we call it cardinal cap is because, let me show you, what is this? This is it. So this is everything about anthrax. But look, it leads to a hemorrhagic inflammation of the brain. So look at it. You see the cap of the Pope, right? So we call it a cardinal cap. So because of the hemorrhagic inflammation of the brain, on top of the brain, it looks as though the person is wearing a cap. And that is why it's called the cardinal cap. So if you check, they say microscopically, there is a serous hemorrhage inflammation in the meninges and the cerebral tissue. So that is why you would always go for anthrax in this case. Okay, I guess this is a very easy, straightforward question. They're saying X chromosomes polysomia. What would it be?
47 triple X.
Right. X chromosome polysomia. So X chromosomes that are more. That is why it will be 47 triple X. Straightforward. The kind of test that we do to identify all these stuffs is called the cytogenetic test. Sometimes you're asked about it. The person has Darwin syndrome. The person has triple X. The person has Klinefelter. What test should you do? It's called the cytogenic test. Cytogenetic test, because you're checking the cytoplasm, you're checking the genes located inside the cell. Whereas if it is an enzyme deficiency, we do what we call a biochemical test. You can also be tested. A person has PKU. Which of the following tests should be done? Mostly, the right answer would be a biochemical test. So what disease is this? 47XXY.
That is Klinefelter's.
Klinefelter is correct. 48XXXY.
Klinefelter still.
Klinefelter, thank you very much. So that is it for here. What about 46XX? What disease is it?
That's just
normal. It's a normal female. It's a normal female. So keep that in mind. Right, so these are the keys you're supposed to know, but there is another important thing about the bar bodies. We say that the bar bodies is always an additional X to the already existing X chromosome. So males have no bar body because our formula is XY, but females have one bar body. So their formula would be XX, because the bar body is an additional X chromosome that is located inside neutrophils that have been inside cells that are scrapped from the oral mucosa. So for instance, the person with the triple X, how many bar bodies would they have?
2.
2 is right, because the first X chromosome, we don't count it. The remaining X, that is what we count. 47XXY, the male, how many bar bodies would it have?
1.
1. What about 48XXXY?
2.
2. Guys, are you following?
Yes.
Is everyone following?
Yeah.
Yes.
Okay, great. Nice one. Let's continue. Okay, I think This question is interesting in such a way that it's talking about in homeostatic factors, and they're saying that what is homeostatic factors? What does it mean?
Yes. Are they the clotting factors?
Right, the clotting factors. Homeostasis is mainly about the clotting process. So the homeostatic factors are talking about the clotting factors. We activate them by adding calcium ions to them, and that is done by which vitamin?
K, vitamin K.
Vitamin K is responsible for what we call the gamma carboxylation of the clotting factors. It activates them by the process called the gamma carboxylation, and you would always be asked that in relation to vitamin K. So the right answer here is they're asking you about the way vitamin K is working, and that is by the structural component allows the joining of calcium ions. Which of the following is the structural component? Is gamma carboxyglutamic acid. That is it. Okay, next question. Someone should read this for us.
Administration of doxycycline hydrochloride has caused an imbalance of the symbiotic intestinal flora, microflora. Specify the kind of imbalance caused by the antibiotic therapy.
Okay, so what is happening in this person?
Dysbacteriasis.
Imbalances of symbiotic intestinal flora.
Right. So why?
You're killing off the normal flora.
Right. The person took too much doxycycline, and currently there is an imbalance of the intestinal microflora. Think about the microflora as the good guys or the good bacteria inside our belly. So if we take antibiotics, we destroy them, and they are there because they are supposed to also maintain the balance between the bad bacteria and the good bacteria. So these guys can help fight the bad bacteria sometimes. But when you take too much antibiotic, you end up destroying them as well. So the person can easily suffer from a gastrointestinal disease. So what is this disease called, first of all?
Dysbiosis.
It is dysbacteriosis. This means abnormal bacteriosis. It is not bacteriosis. Bacteriosis means an increased level of bacteria. But this bacteriosis is an imbalance of the bacteria, right? So, or abnormal balance in the bacterial content. How do we treat this? What do we give the patient?
Probiotic.
Probiotics is correct. What is the other name?
I think it's pre and pro. You give pre and probiotics, yeah?
Right. What other name? You're right. What other name do we use in K apart from eubiotics? They are called probiotic. Probiotic. Okay, keep that in mind. You can sometimes use that. So probiotic or eubiotics are used to treat what we call any dysbacteriosis, and their main component is just replacing the normal intestinal microflora. Here are the keys that you need for it. There you go. Okay, next question. The person has alcoholic psychosis, and they asked a very important question. You shouldn't pay attention to everything. Look at what they ask here. What's neuroleptic? Yeah, we know psychosis. We need neuroleptics to treat them, but they were even more specific. What neuroleptic should be given? Which of the following should be given?
Aminazine.
Most people choose diazepam. Diazepam is not a neuroleptic. It is what we call a barbiturate. It is a barbiturate drug. A benzodiazepine drug. It's a benzodiazepine drug. Keep that in mind. Diazepam is a benzodiazepine drug. So what it does is, what is the mechanism of action of diazepam?
Does it activate GABA receptors?
It activates the GABA receptors. So which means is there mainly when you are tested about diazepam, they always like testing you on seizures because it's the #1 drug that we like using for seizures. So diazepam, in most cases, think about seizures or think about anxiety. But every time psychosis, think about aminazine. The other name they can use is chlorpromazine. Chlorpromazine. What is the mechanism of action?
But if it says alcohol withdrawal symptoms, then it is diazepam, isn't it?
Yes, but in most cases, you would see at the latter part of the question that the person is having seizures. Alcohol withdrawal syndrome with seizures. So the seizures in most cases would be there. So that would be diazepam. Okay. Aminazine, mechanism of action.
Dopamine blockade.
Dopamine blockage. Side effects.
Lactation, like increasing.
Tremor. Right, the way you guys are speaking, it looks like you are right, but I didn't hear very well. Okay.
Extrapyramidal side effects.
Okay. The major side effects are mainly lacturia and Parkinsonism. So guys, surprise me with this question. A person is having a yellow skin and they're asking which enzyme would be deficient. Which of the following could be deficient in a 2-year-old baby?
UDP.
It's UDP glucuronidtransferase. That is what we explained before, that in case UDP glucuronidtransferase is absent, what do we see in the blood? What will be increased in the blood?
Unconjugated.
Unconjugated bilirubin. Unconjugated bilirubin. When there is too much unconjugated bilirubin, we just see what we call jaundice. So the sign on the skin is jaundice, the yellowish presentation of the skin. Okay, again, the same diagram. Okay, here the person is talking about disrupting in the
unconjugated bilirubin.
Oh, okay. I guess your network is now receiving me. Anyways, over here, they are saying that there is a disruption in the coordination of movement. The most important organ for the coordination of movement is our cerebellum. Think about cerebellum as seizures, and is there to trim the impulses for movement so that instead of moving like this, you just go smoothly. Can you guys see my hand?
Yeah.
Yeah, we can see it.
Yes, instead of moving, so the impulses are sent in haphazard way from the cortex to the cerebellum, and the movement is like this, like anyhow. But the cerebellum actually keeps it in a way or in a balance that it moves without any tremor, or it coordinates the movement very well. So that is why the right answer will be the cerebellum. So look at it here, you can see the function of the cerebellum. You can see the function of the medulla oblongata. I did that for those who choose. I did that for those who choose the medulla oblongata. So medulla oblongata is mainly an area for cardiovascular, respiratory, and digestive system controls area. Is the area for cough, is the area to control breathing, and the area to control the cardiovascular system. Cerebellum, on the other hand, when there is an issue with the cerebellum, we see ataxia. Ataxia is the uncoordinated movement, like the person is moving anyhow with their hands. When they're trying to reach something, they move this way. Okay, keep that in.
Drunk.
Right. Okay, this is a very interesting question. The person had a super distended blood, the super distended atrium, and they are saying that this is our key. Let's try and find the key. There is decreased reabsorption of sodium and water. What is happening? Which of the following would it be? What do you guys think?
Natriuretic hormone.
Higher urine.
Okay, so over here, the right answer is natriuretic hormone. Natriuretic hormone. See, aldosterone and natriuretic hormone, they perform opposite function. Aldosterone absorbs sodium, and clearly after they absorb sodium, water will follow. Water would also be absorbed automatically. Natriuretic hormone excretes sodium. It doesn't allow the absorption of sodium. So if we don't absorb that sodium, what would happen? The water as well would be excreted, isn't it? right? Automatically. Vasopressin, on the other hand, has nothing to do with sodium. It just absorbs water. So these are the keys. I want you to remember it as aldosterone absorbs, AA, aldosterone absorbs, whilst natriuretic hormone urinates. So natriuretic hormone, you urinate the sodium, aldosterone would absorb. Whereas vasopressin, vessels loves to contain water only. So vasopressin is only for water. Let's go next. What happened in this question? Okay, so guys, anyone read this for us?
Autopsy of a 28-year-old patient who had been suffering from rheumatism and died of a heart failure revealed pancreatitis, histological investigation of myocardium of the left ventricle posterior wall and interventricular septum, detected perivascular cellular focal infiltrates composed of macrophages and creating palisade structures surrounding areas of fibrinoid necrosis. Determine the type of myocarditis.
What do you think is the most important key here?
Focal. Palisade structures.
What?
The palisade structures surrounding.
Palisading structures is the most important word here that would not make all the other ones possible. Because see, all the others are a form of inflammation. Mainly, they are not the exudative, but it's mainly the proliferative part of inflammation. The most important one here that is different is the granulomatous inflammation. You are supposed to know by heart the contents of a granuloma so that when it comes anywhere, you go for it. Whenever you see palisading structures, that means that macrophages have turned their shape to become like a slipper shape. When they become the slipper shape, they become that way because they want to form a barrier. Let's look at the picture. So look at them. These are the macrophages forming a palisading structure around it. So whenever you see palisading structures, macrophages that are forming palisading structures, it takes off all the others and it only leaves our favorite friend, a granulomatous inflammation. It was my favorite word in pathology. Another word that I like a lot was sarcoidosis because of Dr. House. I don't know if you guys watch it.
Yes, he always talks about sarcoidosis and amyloidosis as well.
Amyloidosis, yes.
Yeah.
When I was
it's never lupus.
Yes, it's never lupus. When I was in high school, when I was in med school, in first year, and they keep, and I watch Dr. House, they see sarcoidosis, lupus, and all of that. I think they're mentioning big words. I'm like, oh, like, when would I ever know this? And then when we did sarcoidosis, when we did lupus, I'm like, I now understand why these guys always use it for a differential. That is all they know, because sarcoidosis, lupus, and then amyloidosis always they are systemic diseases, so always you can use them for anything. Even if someone has headache, you can tell them, oh, maybe it's sarcoidosis, maybe it's lupus. So it's a nice thing of differential. When you are confused, when you are talking with your medical reg, if you are confused anything, say, oh, it can be lupus, it can be sarcoidosis. Okay. But when they start asking you, but why can it not be sarcoidosis? That would be a problem. Anyway, so this is the key, the granulomatous inflammation, the palisading. They gave other keys, but what gives it away is the macrophages forming the palisading nature. Okay, this question, is someone read it for us?
Autopsy of a 5-year-old child revealed in the area of the vermis of cerebellum a soft grayish pink node, 2 centimeters in diameter, and blurred margins and areas of storage. Histologically, this tumor consisted of atypical monomorphous small round cells with large polymorphous nuclei. What tumor is it?
Okay. When it comes to this question, in tumors of the brain, the most important thing is mainly the location first. So whenever you're trying to find a medulloblastoma, it's located in the vermis of the cerebellum and the medulla oblongata. So medulla oblongata, the closest organ to the medulla oblongata is the cerebellum. So always they would bring the vermis of the cerebellum. That is your one key. So that's the best way to identify the brain one. A neuroma is normally seen in amputation. It's just a benign tumor of the nerve. That is the peripheral nerve. Mainly when there is a benign tumor, we end up seeing what we call the verrucase body in the test. And so whenever you see the verrucase body, you go for a neuroma. An astrocytoma, tumor of the astrocyte. So in a microscopic description, that is where you can get it. Because astrocyte, the word astro means what? A star. So for astrocyte, they will tell you that the cell is made up of several processes. A meningioma, benign tumor of the meninges. So they'll tell you that it is attached to the meninges. A glioblastoma, tumor of the cerebrum itself. So they will tell you that it's located in the brain, in the hemisphere of the brain itself. And it can lead to necrosis and it can also lead to hemorrhage. Melanoma is a cancer of the skin. It is a malignant tumor of the skin melanocyte. And nevus is a benign form of melanoma. If you don't understand the word between benign and malignant, write it down right now. Go check what the difference between benign and malignant tumor, and also check how to name the tumors. Very important. Because the way you name the tumors, if you know that alone, you've already answered 50% of the question. Okay, let's go. Next question. Yes, this is very identical. So the person is having an issue with they're saying hyperplasia of the tubular bones, splenomegaly, hepatomegaly, and enlargement of all group of lymph nodes. And the right answer here is a chronic myelogenous leukemia, because guys, think about it. They started with the bone. So far as it has an infection or it has an issue with the bone, then it's a myeloid origin. The next thing to look at is, to know whether it's chronic or acute, we are supposed to look at, is there a splenomegaly, hepatomegaly or not? If there is, then that is a chronic. If there is not, then it is acute. So keep that in mind. In other words, the chronic lymphocytic leukemia can also lead to the splenomegaly, hepatomegaly, and inflammation or enlargement of all lymph nodes. But the only difference is that with that one, sometimes you don't have a hyperplasia of the bone. So hyperplasia of the bone just means a myelogenous leukemia. It's chronic, that is it. The multiple myeloma, on the other hand, would only have to do with the lytic lesions of the bone. And for them to testify multiple myeloma, they would always have to talk about either amyloidosis, or they would have to talk about what we call the paraprotein and Benz-Jones protein. If you see paraprotein, Benz-Jones protein, then the right answer would always be multiple myeloma. Okay, are we clear? What is the question?
No, I think it's clear. I was going to ask why not multiple myeloma. So I think you said paraprotein in the blood and Benzone's protein in urine. That's the key for multiple myeloma.
Exactly so. Okay, let's see. Let's go to the. Oh, what is Zoom trying to do to me? Okay, this is an interesting question. Is this? They are telling you about what is the difference between a normal immune reaction and an allergic reaction. What do you think it is?
A lesion.
It is a lesion. One guy is good for the body, and the other is just destroying the body unwantedly. An allergic reaction is, we either call them hypersensitivity reaction. Hypersensitivity meaning they are overreacting than the way we should do it. mean, we didn't send you to do something, but you're overreacting and they end up destroying our tissues. But for the normal immune reaction, even if they destroy our tissue, it is for our own good because they want to neutralize the bacteria. So the right answer here is the development of tissue lesions. Tissue lesions, very important. Okay, next one to look at is the person has what we call, they're saying that the person cannot respond to reflexes that has a light stimuli, which means that his eye, reflexes that involves his eye cannot be sensed. So which of the following are the transitional, or they are the area of transition when we are talking about the pathway of the eye? So you're supposed to know the pathway of the eye, that is the first order, the second order, the third, and the fourth order neuron of the eye. And the right answer here is the anterior quadrigeminal body. I've realized that most people get confused with the posterior quadrigeminal body. So first of all, stimuli of the eye or stimuli of light can only be determined by the eye. And one of the pathway or the pathway of the eye, the area that is mainly responsible for reflexes is the quadrigeminal body. We have the anterior quadrigeminal body. In other words, it's also called the superior quadrigeminal body. And we have the inferior quadrigeminal body. In other words, they can be called the posterior quadrigeminal body. So this, they have two names. And sometimes they can be used interchangeably and you can get confused. Anterior quadrigeminal, also known as superior quadrigeminal. Posterior quadrigeminal, also known as inferior quadrigeminal. All of these are located in the midbrain. The anterior ones are mainly for what we call reflexes of the eye, and the posterior ones are mainly for reflexes of the ear. The way I want you to remember this is your eye is located anteriorly, your ear is located posteriorly, isn't it? Easy peasy. Are we clear?
Doctor, can you say that again? So
the way I want you to remember it?
Yeah.
Okay, the way I want you to remember it is your eyes are located anteriorly, so the anterior quadrigeminal body, whereas your ears are located posteriorly, so your posterior quadrigeminal body. Okay, and that
makes sense. Thank you.
Sure.
Is the quadrigeminal body the same as the superior and inferior colliculus?
Yes, it's the same as the colliculus.
Like, will they use both, like those terms?
They use colliculus. You hear anterior colliculi or posterior colliculi, and that's why I brought here the corpus quadrigemina and or the colliculi. Okay. So they can be used as well. So you see, with Krok, right? Most people say there are a lot of questions or there are a lot of things that have to do, there are a lot of changing of questions, but that is not the case. You're just supposed to know the knowledge in its entirety. If you know that, wherever they use or whatever channel they pass, you tear it apart, you smash it basically. Our next question is about, can anyone, okay, I guess this is very easy for us. But why is it very easy? What is the last part that we are very concerned about? What disease is this?
Amyloidosis.
Amyloidosis, why?
Congo red, they used
Congo red, very important, and the person had a long inflammatory disease, osteomyelitis plus Congo red on the glomerulus. So this is a secondary amyloidosis. So guys, please, amyloidosis, you can never make a mistake out of it. But the question I also wanted to ask, what is calcinosis?
Don't.
What is calcinosis? Oh, nobody knows calcinosis?
Is that not like a type of dystrophy with calcium, like calcium calcification?
Yes, we have two types of calcinosis. We have a dystrophic calcinosis and a metastatic calcinosis. If we had a question about that, we'd look at it. So calcinosis, to identify it, always you would hear that there is a white substance, a white amorphous substance. And sometimes they will say that it is positive to cause reaction. We have two types. We have what we call a dystrophic one, and then we have what we call a metastatic. The metastatic calcinosis is mainly seen, it's a type of calcinosis that we see in several organs. Metastasis means traveling to different places. So it explores, go to several organs because there is increased calcium inside the blood, mainly because of increased parathyroid hormone. So parathyroid tumor, increased amount of calcium in the blood, leading to increased calcium deposition in several organs. So you would hear there is calcium, these substances are found in the liver, in the muscles, in the, they'll mention a lot of organs. Whereas in dystrophic calcinosis is only one area. It's mainly located maybe in the heart, in atherosclerosis. So only one area. It means when the cell is trying to die, it accumulates a lot of calcium. Why? You should find out.
Does it also looks like lumps on the skin? Usually we see systemic sclerosis. I mean,
exactly. You see lumps on the skin, and when we bisect, we see white areas. The white should always be there. So that is seen in, yes, you're right, it's seen in systemic scleroderma. Okay, this question about sympathetic nerve innervation, heart contraction. Heart contraction has to do with calcium entry. For the heart to contract, we need calcium to enter inside the myocardium so that it can bind to what? Can anyone help me? Calcium enters the myocardium, what would it bind to if we want to do contraction?
Troponin C.
Troponin. And the troponin will lead to a configural change in the tropomyosin. The active sites would appear, and then the head of the myosin would bind, and then we have the sliding movement, right? Beautiful. And the next is about, they're asking about how we can separate proteins. Here, they said serum proteins, and they're asking, what method can we use to separate them? It is electrophoresis. What is dialysis?
It's kidney
failure.
It's in kidney failure, so normally we use it to separate contents of the blood. What about spectrography? This is chemistry. I mean, it has nothing to do with medicine.
It's differentiating based on atomic mass.
Right, beautiful. Thank you. I remember about the mass spectrometer. Okay, so that is it. These are the two most important ones you're supposed to know: electrophoresis and dialysis. Next thing to look at is our favorite friend, MAO, monoamine oxidase. The monoamine oxidase is there to make sure that we break down catecholamine. Sort of, it is the acetylcholinesterase of adrenaline, noradrenaline, dopamine, and serotonin. These four guys, they are broken down by monoamine oxidase. They only don't break down acetylcholine, but these four guys are broken down by monoamine oxidase. As the name implies, monoamine oxidase, the way they do their action is by oxidative deamination. The word monoamine oxidase. So with that alone, you can guess it is not carboxylation. It is not. The formation of noradrenaline, adrenaline, and dopamine is by decarboxylation, but their breakdown is by oxidative deamination, which is done by monoamine oxidase. The therapeutic importance of pharmacology is that monoamine oxidase inhibitors are used to treat depression, because if we prevent monoamine oxidase from breaking them down, they will stay in the synaptic cleft, and we know that all of these are excitatory neurotransmitter. So it would increase excitation, which would take away our depression. Beautiful. The person has hyperthyroidism, they have a urolithiasis, hyperparathyroidism, they have osteoporosis, and they're having a urolithiasis. This is the key. Hyperparathyroidism. What would we have in the blood? What would be increased in the blood?
Calcium.
Calcium.
That is why it is calcium phosphate, because hyperparathyroidism would increase calcium in the blood, which will lead to accumulation of calcium that would deposit inside the urine, the urinary tract, which would prevent the urine from flowing. And then we get this friend, urolithiasis, blocking of the urine by stones. And they're asking, the stones in this case are made up of what? Calcium. Uric acid increase would happen in what?
Gout.
In gout. Gout is the right answer. So we see uric acid in. So if the question they asked you about person is having joint pain and there is gout, which of the following can form kidney stones? You're thinking about uric acid. If they were asking you about the person is having a breaking down of the red blood cells or the issues with cholelithiasis and all of that, you are thinking about bilirubin. So in that manner, you should just know the component very well. So these are the key. We have cysteine and we have bilirubin, but the most important are the first two. Okay, so here they are asking you about novocaine, local anesthetic. They say that they are used to block channels, so they are used to block membranes. And they're asking you that such mechanism of drug action is called, most people choose receptor. This is not a receptor, it's a channel. So they are membro-ionic channels. So look at it. Look at this. These are channels, not receptors. Channels are transmembranous protein that allow the passage. They are like pipes inside the cell membrane. So the right answer will be membro-ionic. The next answer they choose is a direct chemical. No, this has nothing to do with that. They also choose an anti-enzyme. No. Enzyme. No. So the right answer is mainly membrane ionic because we are dealing with ions. Local anesthetics, they block these receptors, not the receptors, but they block the channels to prevent them from entering. Parkinson's disease, whenever you see it, you don't think twice. It's always what?
Substantia nigra.
Parkinson's disease is always substantia nigra. If they're asking you which of the following is involved in Parkinson's disease, it's substantia nigra, which we call the black substance, Other people choose the hypothalamus. Hypothalamus is mainly for sensation of hunger, taste, temperature, and it also releases hormones. But Parkinson's disease is mainly decreased amount of dopamine release, and dopamine, interestingly, are mainly produced in the substantia nigra. Guys, are you following?
Yes.
Yes.
Yeah.
Okay, great. Okay, I don't know why there was a lot of mistake here, but they're saying that the systolic pressure has decreased, the diastolic is 70. Both have decreased to an extent, but the systolic has decreased more. And we are saying such blood pressure is caused by decrease of which of the following factor? Guys, the main factor here is about if systolic, what is systole? What is systole?
Contraction of the heart. Ventricular contraction, left ventricular contraction.
Yes, it's a left ventricular contraction. Basically, systole is just contraction of the ventricle. And the left ventricular contraction is the one we can mainly measure because left ventricular contraction is what brings the blood to all parts of our body. So that is why the right answer should be the pumping ability of the left ventricle. The pumping ability of the right ventricle, you can only determine it by the lungs because it pumps blood to the lungs. But for the periphery, it's mainly by the left ventricle. The left ventricle pumps blood through the aorta to get to all parts of the body. So that is it. You keep that in mind. Next is about the person is having hallucination and convulsions. The only one here that you can choose is GABA. Why?
Inhibitory.
Exactly, that is the simple answer. GABA is an inhibitory neurotransmitter. Convulsion is too much excitation. A person is having serious convulsions. It means that they need GABA, or it's either they are having that because GABA, which is an inhibitory neurotransmitter, is not there to measure or to decrease the level of excitation. So the right answer here is mainly the GABA receptor. All the others are mainly excitatory neurotransmitter. Such reaction is the result of antagonism with the following neurotransmitter. So if we antagonize dopamine, we would rather have depression. If we antagonize acetylcholine, our muscles would not even move. So GABA, if we antagonize it because it's inhibitory, we would have too much excitation. Right, keep that in mind. The mechanism of action is just to increase the chlorine inflow. Right. Okay. Sex chromosome was detected during examination of a man's buccal epithelium. They are saying that one sex chromosome or any sex chromosome was detected in a man's buccal epithelium. Should a man have a sex chromosome? Should we be able to identify a bar body in a man?
No.
No. So if we identify it, it means there is an additional bar body to their formula. So the formula would be either XXY or XXXXY. They didn't say whether 2 or 3 were determined, but let's imagine only 1 was determined. So the formula would be XXY. The XXY in this case, what do we see? The right answer would be Klinefelter's disease. So Klinefelter, that is Klinefelter. So guys, this diagram, you're supposed to know it by heart. Like when they mention part of chromosome 13, even if you are sleeping anytime, because whether you like it or not, there will be one there. And so you can secure your 1 mark easily, easy peasy. Okay, over here, the person is having an inflammation of the intestine, and they're asking you that the bacteria is rod-shaped, all the others can be rod-shaped, but the antigenic structure is this, O- or O-111, and that is for E. coli. So the right answer will be coli enteritis, coli enteritis. And that is it. And you're supposed to know as well, I mean, I've added here about the way E. coli acts on the endomedium and the way Salmonella acts on the endomedium. When it comes to microbiology, they like asking these questions. Okay, the next question, the person is arriving from Nigeria after an earthquake. Chemoprophylaxis of malaria. So this is the most important part. I don't know why they are talking about earthquake, but this is the most important part. Chemoprophylaxis of malaria. So which drug should we give in case of malaria? Okay, the interesting thing is over here, the only drug they have is chingamin. Okay, so that is why they are always talking about it. Chingamin. Does anyone know what chingamin is? What drug is that?
Chloroquine.
Chloroquine is the right answer. Chingamin is chloroquine. Chloroquine is a very famous drug when it comes to malaria. These days, we don't use it anymore because there's a lot of resistance. It was the You said?
He said they use artemether right now.
Yes, artemether tremefantine. The most tasteless drug, the most annoying drug that I've ever tasted in my life is chloroquine. Whenever we had malaria those days, they will come and give us chloroquine, and you don't have an option to take it. Other than that, you take a concoction. And concoctions that come from the farmland is sometimes, I don't know, that one, they don't have doses. So you take about 1 bottle, 3 bottles.
After concussion.
Yeah, so that was just by the way. Okay, these are a very fine guy. A student is having dry mouth. The mechanism. First of all, dry mouth. Is it sympathetic or parasympathetic?
Sympathetic.
Sympathetic. The person is taking an exam that he's having this dry mouth. He's taking an exam.
Condition.
Is taking exam innate or is not innate?
You say what?
Is it an innate mechanism? I mean, the reason why he's feeling the way he's feeling, is it innate or it's not an innate?
Non-innate.
Not innate. So that is why it's a conditioned sympathetic. Conditioned sympathetic. It is not unconditioned. Unconditioned means that it's something you came with from birth. It has nothing to do with emotion. So unconditioned sympathetic is an example. You immediately walk into a room where it's dark and you have pupillary dilation. You have no control over it. You are not thinking about it. It happens automatically. But conditioned one would always have what we call, they will always have some sort of reaction. They will always have some sort of emotions attached to it. Okay, great. So yes, I think we are done. For now, Suhair, are you here?
Thank you very much, Dr. Mustafa. That was really good. Thank you. How's everyone so far? I know it's been quite a long one. How's everyone feeling at the moment?
We're okay.
All good?
Feeling fine.
Good.
Really good, yeah.
Thank you. So as you can see, we've got Krok now coming in June. So hopefully a couple of months, not long to go. We just started our second semester. So we're going to be really busy as we've done last year with a lot of our time being occupied mainly by homeworks and MCQs. So we have two classes, as we've discussed earlier, Class A and Class B, as you can see the website. Class A is pretty much filling up now, and it's only 15 places left for Class B. So anybody interested, we're not going to waste your time. It's going to fill up by itself, so go for it.
Guys, can you mute? Can someone mute it, whoever is talking?
Yeah, that's it. And whoever is in the WhatsApp group, I'll be sending for the next 4 weeks MCQ questions. We'll discuss where to start from, and then you'll get your answers automatically from the MCQ. And when we have these classes, the 10 classes, the 10 intensive days, so this is going to be near, Dr. Mustafa, are you able to go to the website? It'll be easier to look at the website. So this will be near June and May, just before the exams. And the main aim of this is to have a 10 days of consolidation, not only the most important exam papers, but also go through all the topics, all the 9 subjects into a high yielding notes. Dr. Mustafa will go through. So if anybody's late joiner or busy or working or got family, this is the kind of course that would help give you extra support. Because if any of us fail, unfortunately, by a few marks, the product exam, then what you're looking at is studying all over the summer, which is the last thing you want to do. Not working, it's going to waste a lot of time. And that's the last thing we want. We shouldn't be even thinking about any kind of resets or resits, which need to clear Krok 1 in the first time, because we want to look forward to starting our placement and all of these additional things that's happening at the moment. So I'm not going to take a lot of your time. Please, if you want, everything's there for you. Any questions you want to ask myself or Mustafa, please go ahead.
I have a question. So with this 10 intensive days, what are the timings? Like, what will be the hours and timings? Has it been decided, or?
It really depends on each class, because it's going to be only 15 limited. That class, subclass would determine what suits for them, because some people will still have lectures, some still will have different things. So it's just fitting within that days. So that class will decide nearer to the time. As soon as this is filled up, what we're hoping this week, both classes, then that class will make their decision.
Okay, because I think some of us have already booked it, and we just want to know whether it'll be like daytime or evening time, so that we can accordingly change our schedule. So
yeah, it'll be a mixture of daytime and because the way each class is going to be one paper that will be given in the morning. You do the paper, then go through the theory, or let's say, for example, today you're going to do pathomorphology or the high yield notes. Then you go through the exam paper. Then at the end you do it. So it's just going to be really intensive. So you do a paper, you go through the training of it, and then you go through this theory, you go through the answers, and then you redo it again. So it's going to be really that kind of really intensive, where you go through the most important. I mean, for Krok, they consider the last 5 years to be the most important papers, but we're looking at the last 10 years. But if anybody joins this group, then the MCQ will start from next week.
okay. So the people who have already joined, for them, the MCQ starts from next week.
Yes, so their group will be starting straight away at MCQ. So it will be self-practice and in discussions, small discussions all the way through. But that 10 days is the 10 days where you just consolidate everything. Because by the time we go to June or end of May, we've pretty much forgot all the pathomorphology we've studied from September.
Yeah, sure.
Okay, so I guess the point that he's making, I mean, in a nutshell, I think when Suhail contacted me, he made me understand that some people are workers, and some people would need extraordinary help or extreme help when it comes to the latter part, so that they could consolidate all the knowledge, because most of the time when you're studying here and there. And so what we're trying to do is, you see the way I handle the classes, in most cases, we want it to be all round, like every possible answer, every possible question that can come around that knowledge, you should know it. So that when you go and sit in that exams, you don't complain of any sort of new questions at all, because everything is owed to you. So basically from now, you will be solving MCQ questions constantly. We'll be monitoring your progress throughout. We will not be having classes, but every week you will have MCQs. We'll be monitoring your progress and we'll be giving you feedback on the way you should be preparing. Based on the questions that you get right or wrong, we can tell you that you should improve in this side, improve in that side, or what you have, whatever the case is. And then the last, not the last 10 days, but I think the dates are on the website. Those stipulated dates will be having longer sessions. So even me, I'll take a vacation from work then. So we'll be having longer sessions with breaks in between. So we advise that then as well, you guys can take, those that are interested will take breaks. And then we'll be having these sessions where we consolidate the knowledge, and then you would repeat the multiple choice question, and we make sure that you pass those questions. We make sure that you are very well prepared before you ride the Krok, because so far my pass rate has been 100%, so I'm not ready for anyone to dent it. So anyone who joins, whether you like it or not, is a compulsory or is a must that you pass. So the pressure would be given, and all the necessary force would be applied to it to make sure that you get to where you're supposed to get to. Because after all, your most important goal is to pass. I mean, we can't pay this amount of money and then at the long run wait to fail. And then, I mean, it comes with a whole lot of emotions, a whole lot of breakdown of you thinking you can make it, or all of that. You all know the reasons why you choose medicine. I would not speak about how much money you would make after medicine. I mean, that is not my business here. But my major business is that the reason why you decided to be in this course, you need to make sure that you achieve that reason. And part of achieving that reason is that you should be better prepared on the D-Day. So if you're someone that you think you are better prepared, you don't need any consolidation of knowledge, then I don't think this course is yours. But if you need a consolidation of all the theories that we've been studying in the other classes, then this is your kind of class. And we'll meet during those days and make sure that we consolidate the necessary ideas that you need to get you there. Thank you very much. And that is it. So if you need anything, you can contact Suhail for anything. He will be able to help you in that case.
Do you have any questions? Anything else anybody want to ask?
Yeah.